Good morning. I'd like to welcome you all to our 7th annual Global Health Research Convening at Stanford. I'm Michelle Berry, the Senior Associate Dean for Global Health and the Director of the Center for Innovation in Global Health at Stanford University. Each year, we host this event with a few goals in mind. First and foremost, we want to share and highlight the exciting findings of global health researchers, both at Stanford and beyond. Too often, the fruits of our labor go unnoticed and actually get buried in PubMed and elsewhere. And we lose out on the opportunity to collaborate, cross-pollinate ideas, and implement impactful research around the world. Secondly, Stanford is a really big place, and the field of global health is even bigger. This is our chance to meet the many names and faces behind the work we hear about, and mingle and network and find it, although it's an unusual networking on Zoom, we're going to find a way to do that and bring new friends and collaborators together. This is especially important today while the pandemic has added new layers of anonymity to all of us. And lastly, global health is interdisciplinary. At Stanford, we know this well, and yet it is still so easy for us to get siloed in our own little worlds, even when they seem enormous. This is our opportunity to reach out to each other and see how our interests and work really go across many different fields. Because global health is much more than just medicine. It's engineers, it's environmental science, it's anthropology, and much, much more. And now, more than ever, cross-collaboration around the world, not only at Stanford, is of utmost importance. The community of global health researchers featured in this convening involves faculty, fellows, and students from across all schools at Stanford. In addition, presenters and co-authors, excuse me, I guess I'm on, sorry, I guess I'm on video now. Our theme for this year is research during pandemics. 2 years ago, this theme might have sounded hypothetical, even a little unrealistic. Today, we understand that it's a critical field of study, not just because of the direct health implications of a pandemic, but also because of the disruptions to all research that the pandemic has caused. Though not all of the research presented today has to do with pandemics, all of it has been affected by COVID-19, just as all of us have in some way or another. If we have learned anything this year, it's that a global pandemic is truly global, and there are few things left unaltered by such an event, if any. The COVID pandemic affects us all in different ways, but just a few days ago, a very dear friend and colleague of us, and especially of me, Dr. David Katzenstein, passed away from COVID-19 in Zimbabwe. David was a professor of medicine at Stanford, was an active global health faculty fellow, mentored so many students, and dedicated his life to researching HIV and AIDS in Zimbabwe. He was an incredibly generous and kind soul, and I would like to dedicate today's convening and our quest to develop new solutions to global health challenges to David. Before we get started, I'm just going to go over a brief run of the show. Following me, we'll share some remarks by Dean Lloyd Minor of Stanford University. And throughout the webinar this morning, we will hear from 6 global health researchers as they share insights from their projects. These presentations were selected by our center's core leadership. And these are selected to be perhaps, I hope, of particular interest during this conference. Our keynote presenter will be the wonderful Bonnie Maldonado, who will share her presentation, which I love the title, called A House on Fire, an Epidemiologist's Perspective on COVID-19. Bonnie has really been at the front lines of this pandemic and has incredible insights to share with us today. I also want to draw your attention to the chat forum to the right of your screen, and here you can ask questions to the speakers for each session. A selection of these questions will be answered by the speakers after their presentations, and we'll try to eventually get to all of them if we don't, by writing. In closing, I'd like to share a few lines from a poem by the inaugural Youth Poet Laureate, who we just heard from a few days at basically the administration when they swore in President Biden, the inauguration. And this is her piece called Earthrise. Visualize that all of us leaders in this room and outside of these walls or in the halls, all of us change makers are in a spacecraft, floating like a silver raft in space. We see the face of our planet anew. We relish the view. We witness its round, green, brilliant blue, which inspires us to ask deeply, holy, what can we do? I'm asking all of us what we can do, and I want to thank you for your time. Please stay tuned for the special message from Lloyd Minor.
Good morning. I'm delighted to have the opportunity to open the 7th annual Center for Innovation in Global Health Research Convening. I apologize that I cannot attend live with you. I want to start by sharing my deep gratitude to Drs. Michelle Berry and Steve Luby. Their extraordinary leadership strengthens Stanford medicine, enhances the health and well-being of countless communities around the world, and inspires tomorrow's global health leaders. The Center for Innovation in Global Health's mission has never been more critical. The COVID-19 pandemic has laid bare flaws in our global health infrastructure and threatens to exacerbate health disparities worldwide. In the face of these challenges, I find comfort in the center's proven ability to use research, education, and collaboration to improve human health. For example, each year prior to the pandemic, dozens of Stanford Medicine affiliates would travel to help underserved populations in 20 countries around the globe. By teaching, researching, and most importantly, listening, they have decreased the spread of a waterborne parasitic disease affecting 250 million people. As the COVID-19 pandemic swept the country, the center responded swiftly to address its disproportionate impact on minority communities. This response included organizing a team of clinicians who expanded capacity for critically ill COVID-19 patients at Pine Ridge Hospital in South Dakota. Some of the primary beneficiaries of this effort were members of the Lakota Sioux tribe, an underserved Native American community. These are just two of many examples of how the Center for Innovation in Global Health is making a difference. Through its studies of the intersection of global planetary health and human health, the center also shares knowledge in a way that speaks to policymakers and speeds the translation of discovery to innovative, timely solutions. Though Michelle, Steve, and the Center for Innovation in Global Health have accomplished so much, we all acknowledge that so much more remains. I'm optimistic that today's convening will build upon the remarkable achievements we've seen to date and spark innovative solutions that we can bring to the world. Thank you very much.
I want to add my welcome to Dr. Berry and to Dean Minor, to all of you who have joined us in this convening. And thank you, and thanks to Dr. Berry and Dean Minor for welcoming us. My name is Steve Luby. I'm the Director for Research at the Center for Innovation in Global Health, and I get the pleasure of introducing the speakers. So we will now proceed with our first oral presentation of the day. Aditi Onag is an incoming freshman at Stanford University, where he plans to major in bioengineering. Because of COVID-19, he was held back for a little while in Bangladesh, but has leveraged his interest in working with a CIGH-supported team. He's interested in using his knowledge and skills to improve the infrastructure of under-resourced healthcare institutions in low and middle-income countries. We are looking forward to his presentation on detection of airborne SARS-CoV-2 in Bangladesh hospitals. I'd like to remind the audience to please enter questions for each speaker in the chat box to the right of the webinar on the platform. Some of these questions will be chosen to be asked to each speaker. Please proceed, Aditi.
Hi, everyone. As Steve has already introduced me, I'm Aditi Onag. I'm from Dhaka, Bangladesh, and I'm an undergraduate student in Stanford University and a prospective bioengineering major. And today I'll be presenting on the detection of airborne SARS-CoV-2 in Bangladesh hospitals. This project would not have been possible had it not been for the amazing team that I have had all the way from the Division of Infectious Diseases at the Stanford School of Medicine, to the UC Berkeley School of Public Health, to ICDDRP in Bangladesh. So it's been a massive collaboration, and I'd like to thank each and every person who has been on this team and cooperated on this project. Without further ado, I'd go to the background of this research. So as we already know, COVID-19 has stormed the entire globe and has affected us in multiple ways. Back around this time last year, however, low and middle income countries were hit perhaps one of the most as shortages of PPE and other concerns began to rise. Such a country was Bangladesh. When COVID-19 first struck Bangladesh, there were dire statistics that healthcare workers in Bangladesh were facing. For instance, in Bangladesh, it was found that healthcare workers were 35 times more likely to be infected than regular individuals. And throughout this entire time, that more than 120 doctors had died during this pandemic. And this doesn't even include the other healthcare workers whose numbers of infections range in thousands. So what all this meant is that in Bangladesh, doctors and other healthcare workers began to retreat from their workplaces because they were growing scared that despite all the protective measures they were taking, it was still not inadequate, and that wake up each day hearing the death of another colleague of theirs. At the same time, there has been mounting evidence supporting the possibility of aerosol transmission of SARS-CoV-2 in the absence of aerosol generating procedures. There has been research that shows that aerosolized SARS-CoV-2 were found up to 3 stories away from the wards where patients were housed, up to 30 meters away. And there had been instances of super spreading events which could not have been possible simply by droplet infection alone. All these together meant that at this time last year, we were wondering, could perhaps aerosol transmission explain the surplus infection rates observed in healthcare workers in Bangladesh? And that is a question that we wanted to investigate upon. And that is what we wanted to know, whether it explained at least partially the surplus infections that Bangladesh was facing. So that is how we came across our project. So the objectives of our project were twofold. First, that we wanted to measure the aerosolized SARS-CoV-2 in hospitals and in other spaces where healthcare workers operated in. And 2, that we wanted to explore associations with ventilation that we deemed was a possible intervention that could reduce aerosol transmission in these cases. So I'll move on to the study design of our project. Firstly, sampling. So we decided to sample almost 100 wards. It's still an ongoing project, so we've already done approximately 70 and more. So we aim to sample up to 100 wards, and we aim to sample as many hospital spaces as possible. So this is a photo of one of the hospital spaces that our team has sampled upon. This is in COVID ICU, but we also sampled places like COVID cabins, COVID general wards, and even places like non-COVID wards, because we believe that subclinical transmission could be a factor, and even spaces like OPDs and sampling booths where healthcare workers were expected to work but didn't suspect COVID transmission to occur. So these were all the different places that we sampled. So I'll draw a little bit of attention to the picture that I have on the right. There's a lot going on, but I'll just draw a few attention to a few things. So firstly, what we used was a biosampler that's filtered, that took in air about 12.5 liters per minute, and we ran this biosampler for 30 minutes. It was placed 1.5 meters above the ground, where we deemed there would be the highest possibility of finding these aerosols. And it collected a cumulative volumes of 375 liters of air from the room that we sampled in. Aside from the air, we also took a lot of other values as well, because we are measuring ventilation. So the tiny little device you see in the hands of one of my colleagues in this project, that's a device that measures the temperature, the humidity, and the CO2 concentration of the rooms that we sampled in. Aside from those, we also took in other parameters, such as the dimensions of the room, and the area of openings, such as windows and doors, and the number of people in each ward. Lastly, after this air and its contents had been collected in the in the medium inside the biosampler, we quantified the virus using our PCR, using the N1 and N2 genes. So yeah, moving on to the results of our entire project. So first, before we actually received our lab results, we received a lot of interesting observations in the healthcare spaces that we sampled in. First and foremost, I'll get your attention to this scatter plot. On the y-axis, we have like the carbon dioxide values, which is a proxy measurement for ventilation in these spaces. And all the dots correspond to each of the sampling sites we sampled in. So it's very intuitive that as it's more ventilated, as the space is more ventilated, it more and more closer would it be to the environmental CO2 level, that is approximately 400. In fact, the recommended threshold for naturally ventilated spaces is 500 ppm, as per one of the IPC recommendations in healthcare spaces during COVID-19. The corresponding line at 500 ppm is the red line that you see. So what we saw, interestingly, was that the vast majority of wards actually exceeded that threshold. That is to say, the vast majority of wards were operating in conditions that were not ideal for that were not ideal for a healthcare worker to ideally work in, given that these were naturally ventilated spaces. Most of these wards were naturally ventilated spaces. So what we saw was that even whether we detected COVID or not, these wards were at increased risk to the aerosolized transmission. When we did get the result, we found out that 20% of all the samples that we collected tested positive for SARS-CoV-2. And I just want to grab your attention right here. That 20% might not seem a lot, but it's 1/5 of all the values that we collected. Given this is a pilot study which has never ever tested has done a testing of these sorts, the only other document we have is that of a 3.8% rate in a sample size of 35. So when we got 20%, it is much, much higher than what were previous results had shown, and this showed that there was at least significant transmission here. Lastly, that we discovered that although this is something that we're still discovering on the way, we found out that there was a relation to the CO2 values that we're still trying to quantify the significance after we get all the results, but we saw that those with detected had higher CO2 values, meaning that their ventilation was less. Lastly, I move on to one last value that we will use in our final exploration of the study is the rebreathed fraction. So there's a lot of content on this slide, but what essentially does, the rebreathed fraction is the volume fraction of air that is exhaled, that has already been breathed out by someone else. And it's been calculated using the values of carbon dioxide as you see. So I'll just abstract this away and give you an idea of what rebreathed fraction looks like in general healthcare spaces. And this is approximate distribution of these spaces from like 500 to 1,200 ppm. So what you might notice is that a simple value of 1.6% might not seem a lot, However, 1.6%, a value of 1.6% of a rebreathed fraction corresponds to 8 liters per hour of air that's intaked by a healthcare worker from a patient. That is to say, each hour a person intakes up to 8 liters of air from a COVID patient if they're working in a COVID ward, and that can contain, from our PCR values, up to 150 viral copies per hour. So if I look back at one of the plots that we had, you can see how much of a risk all these healthcare workers had with this tremendously high CO2 values, which places them at increased risk. Lastly, our project uncovers a lot of things. Firstly, that LMIC healthcare settings deviate from the ventilation standards because they have exceedingly high CO2 values, that we need simple, efficient measures, such as opening more windows and increasing ventilation to make sure that we are protecting them enough, given ventilation is restrained, and that CO2 concentration can act as an effective measure of ventilation in these spaces. Obviously, there are many limitations of our project, especially since we don't measure viability and it's simply a pilot study with only 100 samples. However, in the steps that will follow, we will what we plan to do next forward is to use our wealth of data on ventilation parameters. Remember the room area, room dimensions, and use that to analyze the degree of risk. And we further want to explore other places where we suspect COVID transmission could be occurring. For example, a large number of patients that admitted were older patients, but we plan to test for aerosolized particles in the presence of people who have not yet tested positive for SARS-CoV-2, and in other locations where healthcare workers can operate in. So with that said, I will be happy to answer any questions that may arise at this point.
Thanks, Aditya, for that interesting presentation. We have a question from the audience. Will these results help inform or influence a change in ventilation in healthcare settings in Dhaka? What do you think?
Yes, I do believe that it will, because what we discovered is that largely that we get a lot of, in the spaces in low-income countries, not only in Dhaka, a lot of these workplaces where healthcare workers operate in have very high CO2 levels, as I showed you in the diagram. And if it is indeed the case, one of the most effective ways that one can reduce CO2 levels and increase ventilation is perhaps opening doors. That is something that we are investigating in this study, and we will soon have data regarding what is the best way to ensure that we have as good as ventilation as good as possible. So yeah.
Second question is, to what extent was PPE available in these settings? Were you able to account for that in your research in terms of assessing the increased healthcare worker infection rate?
Firstly, I think surplus infections are not only a product of simply this, and that's something I acknowledge, that probably surplus infections have occurred due to a multitude of different reasons. One of them could have been PPE. And what we suspect is that the airborne transmission could also be a factor. And given the results, it seems to be that it is likely at least a small factor in these surplus infections. Regarding my specific observations with PPE, we have found that most of these doctors and healthcare workers did follow the recommendations that they were given in terms of following PPE. Nowadays, we see there has been a rise in the practice of wearing double masks. But what happened is, even last year, I personally saw that many doctors were using double masks in their healthcare spaces because they were so concerned about all the news circulating and all the deaths of their colleagues. And therefore, I believe that they did, to the best of their abilities, wear the appropriate PPE. However, I do acknowledge they might make mistakes while wearing it, and there is the reduced efficiency especially when they have never worn PPE ever before. But we think it's a combination of different factors, if not one. So yeah.
Well, thank you very much, Aditya, for a clear and exciting presentation. We are really thrilled to have you as part of the Stanford community, and look forward to travel restrictions being lifted so that we can even continue to work side by side. So thank you very much. Now I'd like to introduce our second speaker, Dr. Ashley Stachinsky. Ashley is an infectious disease fellow with research interests in epidemiology, global health, emerging infections, and antimicrobial resistance. Ashley holds an MPH from Johns Hopkins Bloomberg School of Public Health and an MD from the University of Illinois at Chicago. We look forward to her presentation on rapid development of guidelines for low-cost PPE evaluation and decontamination for resource-limited settings during the COVID-19 pandemic. So over to you, Dr. Styczynski.
Good morning or good afternoon or evening, wherever you may be joining us from. And thank you for this opportunity to share a little bit about this work. The work I'm about to present is not my own. It is a collaborative effort of 15 dedicated and very talented individuals who came together across disciplines, across countries, across continents to solve a pressing global health problem. And that's exactly what we did. As the first cases of COVID-19 began to spread around the world, hospitals, especially in low resource settings, found themselves woefully unprepared. The gravest deficit was the inability to protect healthcare workers with adequate personal protective equipment, or PPE, as I'll refer to it. I was in Bangladesh at the time that COVID emerged. I was conducting research in hospitals as part of a Global Health Equity Scholars Fellowship. I saw the growing fear as healthcare workers became infected, similar to what Aditi mentioned. They saw their colleagues getting infected and some even dying, at least partly due to the PPE supply chains drying up amidst the surging demands from high-income countries. So I reached out to my Stanford community and was pleasantly surprised to find a group of similarly concerned individuals who were eager to assist the international community, some of whom had already begun tackling these issues. Through a series of fortuitous introductions, members of Steve Luby's lab were connected with the Prakash lab, as well as representatives from UC Berkeley and UCSF through the N95 Decon group. The N95 Decon group is a consortium of volunteer scientists who started searching for strategies to decontaminate N95 respirators in the early days of COVID. Soon, we had members of the international community reaching out to us to get involved, and that's how these efforts got started. The impetus for the work, of course, was the rising reports of healthcare worker infections in Bangladesh and elsewhere. Realizing the knowledge about how to use available PPE is the first step in protection, we started with the development of PPE infographics, videos, and training modules for healthcare workers to help them understand how to use the PPE that was available to them. We based these recommendations off of CDC and WHO guidance for PPE use in crisis contexts so that healthcare workers could learn how to protect themselves with whatever PPE was available to them in their context. These resources have now been integrated into a variety of materials that have been translated into 5 languages and made available online through a website. Some of the materials were also incorporated into the Bangladesh Ministry of Health guidelines on PPE during COVID. And just to show you how grassroots this effort was, the model in the top that you see here for many of the instructional photos was my Bengali tutor, who generously gave her time and language skills to make the resources available and culturally appropriate in the Bangladesh context. Our next undertaking was to evaluate the effectiveness of various cloth, surgical, and N95 masks, realizing that there wasn't a standard across the board. This was accomplished through an innovative design of a low-cost particle counter setups, as you can see in the bottom right. The work that we did revealed several important conclusions. One is that methods for measuring filtration efficiency of different materials were poorly standardized, leading to immense confusion on how to compare materials across studies. And 2, even the most optimized cloth masks did not provide even half the protection of a quality surgical mask. And 3, the main difference between a high-quality surgical mask and an N95 respirator is simply its ability to seal to the face. These findings conducted a large randomized controlled trial of the impact of masks in reducing community transmission of COVID-19 in Bangladesh, which is currently ongoing. The intervention arms included an optimized cloth mask that could be produced locally, or a surgical mask. Of all the PPE shortages, the greatest crisis has been and continues to be around the availability of N95 respirators, which is the highest level of respiratory protection. The N95 Decon group that I mentioned previously has been reviewing the evidence for strategies of N95 respirator decontamination. However, very few of these strategies were appropriate for low resource contexts. That's when Tom Baer, who is the director of the Stanford Photonics Research Center, developed strategies to construct UVC decontamination chambers using UVC light bulbs that are frequently available in low resource contexts for water purification. He then used his connections with the Optical Society to share his designs with international partners. These cabinets have now been constructed across 9 countries, including Ethiopia, Kenya, Brazil, and India. In addition, a host of materials has been created around this for safe and effective implementation of this for a user community to continue to expand. Our next undertaking was to evaluate the possibility of decontaminating gloves that would allow for extended use between patients or between patient care tasks. We knew this would require a tremendous number of person hours to complete all of this glove testing. And because of limitations on gatherings and gathering spaces during COVID-19, we designed an outdoor setup allowing us to conduct a modified FDA-approved water leak test. We recruited colleagues, friends, and significant others to help accomplish these efforts. We were able to develop this protocol in conjunction with collaborators at the University of Houston Clear Lake, who have done extensive glove integrity testing, looking at the mechanical factors and how applications of different types of disinfectants affect the integrity. So we tested alcohol-based hand rub, soap and water, and dilute bleach on the impact of these gloves. Overall, we tested over 2,666 gloves, which was just a tremendous effort during the setting of a pandemic. Another thing that we evaluated was the ability of dry heat to be used as a decontamination method. I already mentioned UVC, but an even simpler approach is to use dry heat decontamination. One of our colleagues and collaborators in India was able to repurpose discarded incubators and create dry heat decontamination units that could be used for N95 respirators or surgical masks to allow them to be reused. Another task that we evaluated was surgical mask reusability. Currently, the recommendations state that surgical masks are single use, but we questioned this. And we looked at not only the UVC and dry heat decontamination methods, but we also looked at simple washing with soap and water on the filtration efficiency of these surgical masks. We found that after the initial wash, there was a slight drop in filtration efficiency, but still allowed the surgical mask to perform far better than any cloth mask. These results are undergoing review right now pending for publication, but we're hoping that this can be a useful tool for minimizing medical waste as we explore reuse of some of these devices. So finally, what I want to say is from the tremendous efforts of this international multidisciplinary team, that we can find ways to collaborate and generate timely, actionable solutions to real-world problems through collaborations across disciplines and across universities. Here we had a number of universities outside of Stanford, including, as I already mentioned, UC Berkeley, UCSF, also UC Irvine, Emory, Tata Institute of Fundamental Research, and University of Houston. And most of us have never met each other in person. And this is just how we had to adapt in the setting of a pandemic, but it didn't slow down our progress. And if anything, the challenge and the pressing nature of the questions urged us on forward. And this was also a collaboration across disciplines, including engineering, physics, medicine, epidemiology, and graphic design. Many of us did not speak the same technical language and had to learn new ideas and parameters, including things like flux of air across a mask. But we were all able to help each other through this process and create some tremendous deliverables at the end of this. And the collaboration has been cross-continental from North America to Europe, Asia, Africa, and South America. And we hope that this is just the beginning of this kind of framework so that even when COVID challenges are gone, that when new problems arise, that we can still reach out to our collaborators across the world and across disciplines to come up with novel solutions to these problems. So I just wanted to highlight that there have been more than 7 institutions, 5 disciplines, and 5 continents involved in this project. And one of the exciting effects of this too is just the renewed excitement around these types of collaborations. So one of our partners in India, he mentioned in an email response to some of our documents that the people he's met in the last 8 months have been just so different, a very welcoming, collaborative, and community experience that fills me with hope. So he talked about his eagerness to continue collaborating with collaborators in the US and elsewhere. We've also been able to produce healthcare worker training resources that we hope have been a tool to help healthcare workers during this crisis to be able to better protect themselves so they can continue caring for patients now and on into the future. And even though we designed this around resource limitations in the LMIC context, we also hope that the reusability of PPE will allow extended use that can minimize medical waste. And finally, we've produced strategies for addressing PPE shortages during a crisis, showing that research doesn't have to halt just because of a pandemic. Thank you, and I'll be happy to take any questions.
Thanks, Ashley, for this really exciting presentation on really exciting collaborative work. One question from the audience is, what was your strategy for working across 9 different countries? What challenges did you find, and how did you overcome those?
The challenges were many, including, I think one of the biggest challenges, especially with the UVC cabinet construction, was just availability of resources. So at one point, the decision was made to send a crate of UVC light bulbs to Ethiopia that could be shared with collaborators in Kenya, and to just leverage whatever resources we could. And in this case, one of the fortuitous collaborations was that the Optical Society of America chapter is in Washington, DC, down the road from the Embassy of Ethiopia, and was able to use that as a mechanism for expediting shipping. And so it's not through established channels that we were able to accomplish this, but through these kind of informal networks and just mobilizing whatever we had available to us. And I think people were really willing to kind of go the extra mile because of the severity of the situation, and they saw the value in what was happening. So I think it was just a lesson to us that to keep exploring, to keep asking, and to look for unconventional ways to mobilize.
One more quick question, and that is, do you have any sense of the acceptability of the reuse of surgical masks in these contexts?
I think reuse is a tricky concept. Technically, reuse would be using the same mask even when caring for different patients. And that is already a very common practice in many of these settings, including in the US as the pandemic has gone on. And so the idea of helping people to extrapolate this then from not just between patients, but maybe over multiple days, it does take some convincing, but when we show the data and show that these surgical masks, for example, being reused, continue to offer more protection than cloth masks, people really do want to find better ways to protect themselves. And if they can't afford a new surgical mask every day, they are eager to find strategies. And so I think if you have the right kind of conversations with them, that people have been accepting of this, including in places like Bangladesh, where we've been rolling this out as part of the mask randomized controlled trial.
Well, thanks a lot, Ashley. Really appreciate the presentation and the questions. I now have a great pleasure of introducing our keynote, Dr. Yvonne or Bonnie Maldonado. Now, Dr. Maldonado is really accomplished, but she started off as a medical student here at Stanford. She trained in pediatrics and infectious disease at Johns Hopkins, and then studied epidemiology at the U.S. Centers for Disease Control before, thankfully, coming back to Stanford. Today, Dr. Maldonado is Senior Associate Dean for Faculty Development and Diversity. She is the Taub Endowed Professor of Global Health and Infectious Disease, as well as Professor of Pediatrics and of Epidemiology and Population Health. She also serves as Chief of the Division of Pediatric Infectious Diseases. Her research has engaged epidemiologic aspects of vaccine development, including immune responses to measles vaccine in infants and factors associated with poor immunogenicity of oral polio vaccine in low-income countries. Her recent scholarship has evaluated issues and strategies for advancing underrepresented populations in academic medicine. Most recently, I think the Stanford community is most familiar with Bonnie's clear explanations of sound approaches to addressing the COVID-19 pandemic as a recurring spokesperson for Stanford medicine. We are grateful for Bonnie's many contributions and look forward to her talk, A House on Fire, an epidemiologist's perspective on COVID-19. Over to you, Bonnie.
Thank you, Steve, for that great introduction. And I certainly am grateful to Stanford, overall Stanford faculty, my colleagues, the trainees, and in particular, the global health community here. And I know that you spoke about David Katzenstein earlier. I was unable to be here for another meeting, but I truly, my heart is really broken hearing about the news about him and about James Hakim and our other colleagues who are truly people who led the way for us and really brought us as a community together. So thank you so much. And I do value this global health community. It's been the place where I found my home, truly. So let me go ahead and get started. I wanted to talk my own perspectives, and it's not all going to be epidemiology, but I am an epidemiologist on heart, and I do have a particular view of the world. And again, as a pediatrician and a vaccinologist, there are some areas that I'm particularly interested in, but I want to give you all an overview because I think as I spoke to Steve and to Michelle, what is it that we learned? What can we learn where we're missed opportunities? So I'm going to try to give you a fairly high level overview. So the reason I called this A House on Fire, and hopefully many of you have heard about this book or read it. It is a fabulous book. It's short, but it's very focused and to the point. And it's about the smallpox effort to eradicate smallpox. And this is written by Bill Feige, who is a noted CDC infectious disease epidemiologist. And what he said, and actually he did not this, he attributed it to one of his colleagues in India as he was trying to work in India to eradicate smallpox. And his colleague said, if a house is on fire, no one wastes time putting water on nearby houses in case the fire spreads. They rush to pour water where it will do the most good on the burning house. And certainly in our rush to deal with this pandemic, I think we have been deflected in many ways by putting out embers and not dealing with the fires. And there have been a number of big fires here. So I do love this idea from a social, from a political, from a geopolitical standpoint. But again, as an epidemiologist, this is a very basic epidemiologic principle. What he was talking about essentially was ring vaccination. So this just goes to show you that no matter what field you're in, you can really extrapolate those ideas to other areas. And that's what I've been fortunate enough to be able to do and pivot into the COVID pandemic. And clearly, we still have a long way to go, but I think we at Stanford and around the world have made some important strides and accomplishments. So when you look at this world mapper slide of the global impact, and of course, we reached that horrible milestone just yesterday of 100 million cases worldwide with about 2% mortality. And of course, that's highly underreported. You can see the impact overall of cases. And even though we think we are really at the top of the list, you can see around the world that we are not the only ones that are being impacted clearly. And when you talk to our colleagues in other parts of the world, underreporting is a significant problem. In addition, when you look at mortality, the numbers again bear out the same message that we are seeing mortality rates that are really significant in other parts of the world. And yet the literature and the data and the ability to have tools to fight this pandemic outside of developed settings has really been extremely limited for obvious reasons such as travel and resources, but even more subtle, very low priority at this point for many of the political and strategic decisions. So let's talk a little bit about the impact of the pandemic on global health. So I really go to the Gates Foundation Goalkeepers Report. They did some really nice work, and I'd encourage you to look at it. It's pretty focused and nice, lots of nice graphs. But one of the areas that I think I'll talk about the global Goalkeepers Report, but other areas that I think we need to remember, and I'm not going to go through details here, but just to highlight areas that we really are concerned about and for which there are now starting to be a number of publications of the impact. It's not just COVID deaths and COVID cases that you just saw, But this is a huge impact of deferral of regular care, the impact on life expectancy and global burden of disease, which we have yet to really dive into, but I know from early data that our life expectancy impacts are going to be huge, especially among people of color and people in socioeconomic disparities in this country, but especially around the world. The economic impact I'll talk a bit about. There have been a number of socioeconomic and gender disparities, and this is an area, the gender issue, that I think Michelle deals with very well. I'm going to focus a bit more on socioeconomic and racial and ethnic issues. And then, of course, this vast area of mental health. I believe not only that we are in a mental health pandemic now, but given the situation that when things get better, and we do think they will, that the mental health issues are going to be tremendous in the months and years to come. So if you look at the Global Goalkeepers Report, obviously what they say is that we are losing ground, but they put a number on it. They think that the projection is $12 trillion around the world by the end of 2021. Now, given the national debt or the national deficit of the US, that doesn't sound like a big number to us anymore, unfortunately. But when you look at it in terms of global, the per capita allocation for healthcare and for other life improving resources for people around the world, $12 trillion is a really gigantic number for many places in the world where people do not have access to resources as it is. So the Gatekeeper group, Goalkeepers group did say that every single month, the global economy loses $500 billion and a collaborative approach may shave months off the world's timeline. So again, this idea that there are no borders, we don't need national solutions, we need global solutions. In the US, and I'm sure this is true around the world, but we've been able to document it here, the pandemic has inequitably distributed the economic impact, with people in high-paying jobs actually saving money, while people at the other end of the economic spectrum are having trouble paying rent and keeping food on the table. And this is one of the really important highlights of this pandemic. It has really laid bare that every axis, every single one of inequity, racial, type of job, size of house, quality of internet connection, on every dimension, those who are better off had less of a problem during the pandemic. And in many cases, this is a deadly differential. So if we look again at what the report has to say, they talk about the fact that there's a major backsliding in the percentage of the children around the world, for example, getting essential vaccinations. There's food insecurity that is at a devastatingly high level, and a sharp increase in the number of people living in extreme poverty. And if you remember, some of the goals, the original goals of the Millennium Development Goals were to reduce, and we had made major efforts in drastic reductions in people living in extreme poverty. That's all been erased. In the first months of the pandemic alone, we saw the number of people in extreme poverty rise by 7% after declining for 2 decades. And their summary was, this was back in September of last year, so we are only in more dire straits now, but we've been set back 25 years in 25 weeks. It is really a devastating impact here. And again, most of our global development metrics have been reversed in 2020. We are irretrievably off course to hit any of our goals by 2030 and probably beyond. And we, for example, one point that I, as a pediatrician, look at is our vaccination coverage levels, which are also, again, a very good marker of the stability and the resiliency of a healthcare system, are at levels last seen in the 1990s. And just to remind some of you, we actually had 75% reductions in mortality due to vaccine preventable diseases in those 30 years. So we're going to see a similar impact, I believe, on outbreaks. And indeed, we're already seeing reports of outbreaks of vaccine preventable disease rising because of this lack of access to normal care. And just as an example, this is just one indicator of under 5 mortality. And you can see here in this slide, the yellowish kind of buff line there indicates what our goal has been for under 5 mortality per 1,000 live births. It was about 24 per 1,000. And that was really not even an aspirational goal. We were hoping that's where we would be. And you can see that in the red line here. This is the worst case scenario from the pandemic. And what we're thinking is that we may actually wind up with almost double that number of under 5 deaths. So that's a good indicator of life expectancy, economic stability in the next 20 to 40 years, and many other indicators of health disparities. So let's talk a little bit about epidemiology. And then specifically in the world of elimination and eradication where I live, with the polio pandemic, for example, or the polio, hopefully lack of a pandemic soon, is how is eradication defined and what are biological criteria, and when and how should eradication programs be implemented? I'm not going to go into detail here. I teach a whole class. In fact, we are teaching a class on this, so I don't want to give that away. If you want to know more, you can take the class. But in fact, when we talk about this issue of eradication, elimination, there are many, many approaches. And again, I encourage you to read House on Fire, and you can see one of them that worked extremely well. We eliminated the first human disease from the face of the earth with that. But we have to take into account many issues, and we worked on these not only in real time, but really going on almost no data and really gut instinct based on other pandemics and other outbreaks that we have seen from an epidemiologic perspective to understand or try to understand with SARS-CoV-2 and COVID-19 what modes of transmission might be, what the transmissibility of the organism is, that is infectivity or the R naught, dispersion or the K factor, direct and indirect effects. We needed to look at population characteristics such as herd immunity, homogeneous and heterogeneous populations, and therefore mixing and modeling studies of mixing in order to understand these population characteristics and how we could eliminate disease. And then obviously from my point of view, the vaccination approach. What vaccine do you use and what type of vaccination is going to work? And what are the limits of vaccination and immunity? All of those are things that we jumped on pretty quickly. And I am astounded that despite all of the inequities, we can see that when you do have the resources and the ability to apply those resources, you can move forward. The fact that we have in less than a year 2 tremendously efficacious vaccines is really astounding. That is a testament to modern technology and will, but it's also a testament to the fact that we don't put our resources in areas where we think they're important, because almost no money was given to implementation of vaccination. You can see the impact of that now all around the world, and even in countries like the US and the UK and others. So what are missed research and implementation opportunities? Well, I don't even want to go into all the misinformation that went out there, but they really did drive a lot of this missed research. Part of that was lack of transparency around lockdown and quarantine cadence and impact, the emphasis and study of non-pharmacological interventions such as masking and distancing. Obviously, there were few and far between the small studies, but we needed much more harvesting of our data sets that already exist to be able to be transparent in this area. Understanding successful behavioral approaches. If HIV didn't teach us anything at all, it taught us at least one thing, and that is behavior drives infection. Viruses and bacteria are just there to help us along, but behavior really does drive our ability to control infections. And then finally, the adequacy or lack of adequacy of our surveillance systems to study natural history, the impact of interventions in real time, and transmission dynamics are things that we are just not really tapping in any decent way right now and could be doing a much better job. And then finally, around lessons from the past, and then I'm going to move on to some more granular topics here, is really how do we learn from past pandemics? We can read all these books about the 1918 flu, but very early on, it was very clear that there were going to be waves of this pandemic because it happened with the 1918 pandemic. And there are lessons still to be learned here. For example, it was interesting to note that there was a big anti-mask political platform in 1918 in the wake of the 1918 pandemic. Many politicians lost their jobs because they were pro-maskers. There were riots in the streets about anti-masking. You would think that was last week and not 103 years ago. So in many ways, again, behavior drives the polemics here. And we have not learned from this, or maybe the historians have, but we haven't been able to push those concepts forward. And I do think those are missed opportunities, but opportunities that we can still leverage. Now, what about confronting the simultaneous pandemics of this COVID crisis as well as health disparities? So I want to be a little more granular about what we mean, because I don't think people understand what social determinants of health really are. Here are they in stark outline: poverty, frontline job type, crowded living spaces, crowded public transit, food deserts, inadequate insurance or healthcare coverage, leading to all of the outcomes listed here. These are already in existence, and these are actually driving the pandemic. I would argue that if we did not have such differential social determinants of health, we would have had a much better handle on this pandemic. But there are differentials not only in developed countries, but of course in developing countries. And we have to remember, if for no other reason as for selfish reasons, that if we don't control this pandemic around the world, we will not control it in any part of the world. And for those of us who do global health for a living because we believe in it and we think it's the right thing to do, obviously we need to refocus our efforts on the existing social determinants of health. We are seeing cases that in racial and ethnic minorities, and possibly there may be a biological connection, but all the data points to the fact that these are not biological issues. These are issues around access to healthcare, access to all the things I just showed you in the previous slide. So yet again, another lesson from HIV is we do not want to target our racial and ethnic minorities. And I was always loath to put up those race and ethnic slides because it really singled certain groups out. It's not about the race, the ethnicity, the color of your skin, or what your genes do or don't do. It is about where you live. And as Lloyd Minor likes to say, it's more about your zip code rather than your genetic code. And we are not dealing with this. And outside of the US, we are truly at a loss to really try to understand how to really reconcile this issue of social determinants. And obviously genetics is helpful, but it's not going to solve this problem. The other issue I'd like to focus on very briefly is climate change and global and environmental areas. I know this is Steve Luby's topic, so I will tread very carefully here. But this is an old slide that I really came back to and realized that, again, pulling up areas of disparities. This is a New York Times reporter who was very good, and I actually got to meet her a couple of years ago when we were at a convening that Governor Brown pulled together on global climate change. And she talked about her own birth city of Calcutta and how it had handled previous diseases and environmental issues well, but in the or relatively well, but in the surge of building out and bringing people into the cities, the ability of the city to handle environmental impacts on, for example, the flow of the river Ganges right through the middle of the city was not thought of prospectively and led to lots of overflooding and arboviral diseases, diarrheal diseases, et cetera. And all over the world, you can point to climate issues very easily and health inequities. Now, eventually climate change, and you could argue that even today, climate change is affecting all of us, but we know that it disproportionately affects people in lower socioeconomic conditions first and with more impact. So we need to start to think about that as well. So what have we talked about? Well, there's lots of good words around equity, and I'm going to cite a few of them here, just so that we talk about these around the impact of COVID and equity. Johns Hopkins really said, and the National Academies of Medicine and the World Health Organization have put out statements talking about promoting equity and social justice, recommending, for example, that vaccine access should be prioritized using the Social Vulnerability Index, or the overarching goal is to contribute to equitable protection and promotion of human well-being. This is all well and good, but what we're seeing right now in the real world, even here in the US, is and I'm working with this on a daily basis, in fact, an hourly basis at the hospital as we roll out vaccines, We have equity, as we're looking at this from an equity lens all the time. And yet, even those of us who say, yes, we believe in that, will have a colleague who said, but I have a friend and they have a friend, and can you just get them in first? And these are the same people who are talking about equity. So we need to not be that person who says, yes, I believe in it, except when it comes to me. And I am proud to say that I was the last person in the healthcare system to be enrolled to be vaccinated, because I knew that PPE works. And I know that obviously we're all at risk, but I wanted to be sure that every single person had access, including our housekeepers, including our food service workers, and that they were all invited to be vaccinated before I walked in that door and sat down to get the vaccine. So we have to live our principles every single day. Looking at the global scramble for coronavirus vaccines, you can see that again, despite all of those wonderful tropes that we see, look at the distribution of vaccines so far. And this was actually before vaccine actually was produced. The UK had projected 5 doses per capita. The United States, the European Union, Japan, about 2 doses per capita. And the rest of the world kind of just drops off. And we're not even looking at areas of highest risk. So we need to do a much better job. In fact, we need to do something to start to address this issue of vaccine equity around the world. And I'm hoping that our government stands up and leads that way, because we have, I think we have a standing in the world. And if we don't, we need to remake that pennant that we fly of equity for the world and not just for us in the US. Now, around vaccines, my go-to for graphics lately has been the New York Times. And they always track vaccines. We know that we have 2 amazingly efficacious vaccines available in the US now, the Pfizer, BioNTech, and the Moderna vaccine, and 3 others to come soon. So that's exciting news. But again, the equitable distribution is going to be important. And more importantly, how are we going to get these vaccines out into areas that don't even have regular refrigeration, much less a minus 70-degree freezer? So the Johnson & Johnson and the AstraZeneca group have really been looking with an equity lens around the world and building contracts. The Chinese as well have done that. There are vaccines in India as well. I think AstraZeneca just put together a very nice contract with India to start to vaccinate that population. So we really need to push our equity lens out beyond this continent. Talking about the mRNA vaccines, just so you know, these are really well prepared vaccines. It's not a new platform. It's been around for a long time, but it's not well understood in the lay press. It's not even well understood among scientific leadership, but it has been around for a while. But again, this shows you how $9 billion can move something forward pretty darn fast. So mRNA is a blueprint for all protein synthesis. It uses cell biology to activate the immune system, and inherent safety features are present. These viruses do not these vaccines do not self-replicate. They are synthetic mRNAs that do not enter the nucleus. They enter the cytoplasm. They serve as a template just for spike protein translation, and they disintegrate within minutes to hours after that. And then you get a rapid expression of the spike protein on antigen presenting cells. And then you get rapid activation of your T and B cell effector and memory cells. And for those of you who've been vaccinated, you can feel those ribosomes churning away when you get the vaccine. So we need to make that type of technology available, and the companies are working very quickly to try to reduce the refrigeration needs. But in the meantime, other platforms such as viral vector-based platforms and subunit vaccines are traditional ways to get vaccine that might be able to deflect some of the cold chain needs. Now, when I talk a little bit about the studies that have been done, this is just a template to show you that the studies have only, because they were so rapid and involved so many people because of potential safety signals with new technologies, really just looked at transmission, looked at the endpoint being disease. So people who had symptoms that listed here with a positive PCR were enrolled in trials. And you can see a summary here that I put together. Over almost 75,000 people enrolled in the Pfizer and Moderna trials alone. The primary endpoint being PCR positive COVID-19 symptoms, a total of just under, over 300 cases overall. The vast majority of those in placebo recipients within 1 to 2 weeks after the second dose. So 94 to 95% efficacy. And we need to learn more, and we are learning more about immune correlates here and whether or not, for example, the disease, the vaccine can prevent not only disease, but infectivity and infectiousness. And those studies are ongoing. We do know that there are adverse reactions, and in particular, they are mostly local reactions, and the anaphylaxis does occur, but it is at a higher level than average vaccines, but not at a substantially higher level given the benefits and the fact that these anaphylaxis events are actually well controlled in areas where the EpiPens are available. These are technologies that can be used in any setting around the world. So we can make EpiPen and anaphylaxis kits available everywhere around the world so that vaccines can be given out as quickly as possible. This is an interesting slide that I found on a tracker that I've been following for months now. And this is really the 30,000 base pair genome of the SARS-CoV-2 virus, and looking at genotype drift over time. All viruses mutate, but generally they mutate randomly across the genome. And while you do see, evidence of random mutations, you see that here the gene that codes for the spike protein, which is the area where neutralizing immunity is important, you see there's clustering there, likely from selective pressure of immunity against viruses that are susceptible, leading to expansion of clones of viruses that have escaped those immunity to those epitopes. So we have to keep an eye on these variants, but the good news is that these vaccines can actually be developed and redeveloped to address any of these escaped variants. There are 3 major variants around the world. I'm not going to go through them in detail here, but you'll have the slides available later. There's the UK variant, there's a South African variant, there's a the Brazilian variant, and they all have varying degrees of potential for more infectivity. I won't go through the details, but it has to do with the ability of the virus to actually adhere to the ACE2 protein on the surface of the human cell. And the question is whether or not this leads to more infectivity or of the cell versus infectivity overall. That is, do you produce a higher viral load and therefore are you more likely to transmit to others? And also, finally, is there a risk for increased severity of disease? And there's a signal from the UK that is perhaps true, but it's one study that is in preprint and we don't have evidence otherwise. It is likely that mutations, as they do with other viruses, will become the new viruses, or what we call a founder effect. We will start to see some of these founder viruses starting to become the standard viruses within some populations. It'll be interesting to see whether one or more of these becomes a global founder or not. Now, around the therapeutic pipeline, briefly, there are many, many components that are being developed. You can see the breakdown here around vaccines, antivirals, and therapeutics. Again, we need to remember to make as many of these accessible to people in the developing world. So having a 3-hour infusion of a great drug is not going to be helpful in parts of the world where most of us work. We need oral drugs, we need effective drugs, and safe drugs that can be given in any little clinic setting anywhere around the world. Here's the distribution by phase and strategy. So you see, because the pandemic is new, most of the clinical therapeutic pipeline is in the phase 1 and 2 area, but we do have some notable exceptions in phase 3 and 4. And here's the distribution of what I just showed you. So most of the drugs available are anti-inflammatories and antibodies and some vaccines. Now, many of these could be given as sub-Q injections, would be helpful in the developing world. Many of them are antibodies, which there's some recent data, which I'll talk about, which could potentially be given sub-Q. Some of them are oral, and there are even some oral vaccines being studied. So we look forward to more therapeutics that we can use around the world. And just to show you that the vast majority of the therapeutic studies are being done in new drugs, but right now where we're making the biggest impact is in redirected and repurposed drugs, because you don't have to go through all of the safety trials. These have already been drugs that have been tested for many, in some cases, many years. So we hope that some of these repurposed drugs are also useful in global settings. The active trials are ongoing at NIH. I'm the member of a DSMB of one of these, and it's coordinated by the NIH with BARDA, with CDC, FDA, including a broad transdisciplinary approach and around the world as well as in the US. And that includes 5 different groups looking at different approaches to prevention, primarily treatment of disease, and then includes working groups around preclinical work, therapeutics, vaccines, and clinical trials. But I would urge us to think about preventive measures. And in that vein, I'm really excited to come to my second to the last slide here, talking about the fact that the Regeneron trials, which are the two antibody cocktails that we are using here at Stanford and are being done as well, many other sites around the world, have shown that preventive sub-Q injections of this antibody cocktail in people who are not infected and who live in a household where there is a positive individual, an infected individual, have demonstrated in early analysis 100% prevention of symptomatic disease and 50% reduction in asymptomatic disease, with significant reductions in viral shedding and duration of shedding. So this is something that I think if we could scale it up in a cheap and effective way, could be given around the world to do outbreak prevention, not in replacement of vaccines, but outbreak prevention. And so what does the future hold? Well, we talked about treatments. We need treatments. They are going to need to be a combination of all the different treatments that we talked about. Clinical trials must be flexible, adaptive, and equitable. We need biomarkers to measure outcomes so that we know who to target for these trials. Instead of having to do trials on everyone, it would be nice to find the most at-risk populations. Herd immunity and prevention are important, but we have a lot of unknowns at this point, and non-pharmacological interventions such as mask all around the world. So what's the way forward? Well, we have learned that we need to use science and equity, and especially equity, to conquer this virus, and those yet to come. Scientific collaborations around the world have been critical, the unprecedented use of technology, but the uneven distribution of technology has to be highlighted as well. Equity is critical and preparedness is mandatory. So I will stop there, and thank you so much for your attention.
Thank you so much, Bonnie. That's really, it was comprehensive and understandable and really helps us all. It really reflects well on your ability to communicate all of this. We're a little short on time, but I still want to pass on one of the questions that came out of the audience. And that is, when you reflect on your experience with HIV and polio, what do you think the top interventions will be, especially in low and middle income countries, and how optimistic are you about this future?
Well, I'm actually generally have to be. If you work in global health, I think you have to be as well. And I got that lesson from David Katzenstein. Again, he was the eternal optimist. I learned a lot about that from him. But I would say that the critical issue, there's two. One is on a social perspective. We have to partner. There's no such thing as coming in and being the smartest guy in the room. And I purposely said guy in the room. You have to be collaborative and cooperative. That's the only way any of my studies have ever succeeded. And we need to be collaborative. And I frankly, in my view, and I'm an epidemiologist, I work with vaccines, I think prevention is the key. And vaccines are going to be important, but behavioral interventions as well, in order to get the combination of bundles of prevention packages with vaccines and behavioral interventions. So to me, those are going to be the key here. But then the platform is going to be accessible technology and preparing for the next whatever comes along. So hopefully that's a helpful answer.
Well, thanks very much, Bonnie, and just thanks for your whole presentation. We do need to move along now. We really appreciate both your presentation and your whole commitment to quality healthcare and your leadership in this issue, both at Stanford and globally. I'd like to introduce now our third oral presenter, Dr. Pablo Garcia. Pablo received his medical school degree at the Universidad de San Carlos in his home country of Guatemala. In 2018, he completed his internal medicine training in New Jersey, but then came here to Stanford. He's currently a Master's of Science in Epidemiology student and simultaneously a clinical and research fellow in nephrology at Stanford, and is conducting research as a research associate with the NGO Maya Health Alliance in Guatemala. Dr. Garcia's presentation is titled Coronavirus Disease 2019 in Patients with End-Stage Kidney Disease on Hemodialysis in Guatemala. Incidents and outcomes. Pablo, over to you.
Thank you, Dr. Luby. So when COVID-19 started in Guatemala and we started getting more cases, we were very worried about the situation, mainly in our patients with end-stage kidney disease. And Dr. Sanchez Polo, who is one of the senior researchers on this project, he contacted me and he was very interested in understanding what was going on with these patients. So that's one of the reasons that we underwent and we did this study. So initially, when COVID-19 affected specifically high-income countries, but then as time went by, it started affecting countries such as Guatemala or more Latin American countries. And so fast forward in September 2020, we see that the COVID-19 cases in all Latin American countries, more than 200,000 deaths. And in Guatemala, we had the first case in March 13, 2020. So Guatemala is an upper middle income country now. It was a middle income country, low middle income country just a few years back. It's located in Central America with 17.4 million people. 41% of the people are Maya indigenous. And when we talk about kidney disease care or dialysis, it's mainly provided by two healthcare systems in Guatemala. One is the Social Security system, which is an employer-based healthcare insurance system that covers approximately 20% of the population. And we also have the Ministry of Health. And the Ministry of, when we talk about dialysis, there are around 564 patients per million people in Guatemala. And a total of 8,000 patients on hemodialysis. Of those, 5,000 patients are being cared by the Ministry of Health, and around 3,000 patients are being cared by the Social Security. So our objectives was to determine the incidence rate of COVID-19 infection among patients on hemodialysis, to describe the demographics, comorbidities, and outcomes of the affected patients. So our study population, we did the study in the Social Security. So we included, we looked at a total of 3,200 patients with end-stage kidney disease on hemodialysis in Guatemala. Around 15 dialysis centers from this large dialysis network. It was a retrospective analysis. We used data collected using medical records, and we manually extracted the data. It was, we collected data for those patients who were admitted from May 1st to July 31st, and we obtained data up to August 28th. So for example, the patient who was admitted on July 30, we got the data, but we followed them up to August 28, 2020. So we found that 325 patients were diagnosed with COVID-19 with an incidence of 10.2%. The incidence was higher in Central America with in Central region, with a 20.7%, a 25.8% female. The mean age for diagnosis was 51 years old. About 70% of the patients recovered, and 20.7% of the patients unfortunately died, and 45% of those with diabetes died. So here is a map. One of the most important things that I would like to highlight is that we found that some dialysis center on the right upper side of the screen, 31 of the dialysis centers had an incidence of up to 30%. And we also noticed some areas that had less incidence of COVID-19 in Guatemala. And the squares on blue are the incidents that we calculated using the Ministry of Health data sets. And we found that the patients on hemodialysis, the incidence was higher in patients on hemodialysis. Here we are showing the incidence by, we are showing the incidence on the right by percentage. And if we move forward, if we move here, here's the way that the patients, the outcomes on the patients. So of all the patients with COVID-19, we observed that most of the patients recovered, but then unfortunately some of the patients died during time. So the conclusion, COVID-19 incidence in patients on dialysis was higher than the general population. We found that some of the regions had increased incidence of COVID-19 in Guatemala. The death rate was higher than that reported in Guatemala, in the Guatemalan general population. And the death rate in patients on dialysis in Guatemala was similar to North America, European countries, but lower than that reported by the Guatemalan Ministry of Health hospitals, which was around 37%. Patients on hemodialysis should be a priority when we have a vaccine available in Guatemala. So far, as up until today, we don't have vaccines in Guatemala, and that has been a serious issue. Thank you. And just today in the morning, the manuscript was published in one of the kidney nephrology journals. And thank you to the collaborators or colleagues in Guatemala, the nephrologists who are on this picture. Thank you to my research mentor, Shuchi Anand. And as well, thank you to American Kidney Fund who has supported my research and my education at Stanford as well.
Well, thanks, Pablo. This, I think that your mentors should be really excited about your ability to meld your interest in nephrology with an excellent use of epidemiology that really, to me, illustrates the inequity that Dr. Maldonado was talking about. The death rates in these units is just overwhelming. And I realize you say these compare reasonably to other sites. On the other hand, this is a community that is dying from this disease. So you called out a need to get vaccines to Guatemala and presumably other places that have limited access and patients on dialysis. Do you have other thoughts about what might be able to be done with these high-risk communities in order to reduce this devastatingly high mortality rate?
Yes, there are a couple of things that we probably, or then our colleagues in Guatemala did while this was happening, and they noticed that we have a lot of patients who were getting infected with COVID-19. And one of the things that they did, which to me was very interesting and very, they had usually two shifts, one in the morning and one in the afternoon. And then when they realized that some of the patients were getting infected with COVID-19, they opened one shift at night. And so all the patients who had infection, they were able to dialyze at night, and then they had some time to clean the units, and the staff was being more careful with those patients as well. So that is something that it was done before. Then in the Ministry of Health Dialysis Center, I will say that 60% of the patients are getting dialysis with peritoneal dialysis. This means that they don't travel to the city or they don't travel to other centers, which is good because at least they don't have to expose themselves traveling in public transportation. Something that we thought about it is that some patients are traveling to dialysis centers by bus. And in Guatemala, as you know, Dr. Louis, you have been in Guatemala. They travel like in chicken buses and stuff, and they go to, and they get like multiple patients can travel together or by themselves, but multiple people in the bus, and they can get infected. So those are the things that we could like do something to protect those patients. But I feel like now that we have the vaccines, the Ministry of Health, Social Security should work really hard to get the vaccines to these patients first, or at least some of the first wave of vaccines should go towards these patients.
Another question that's come in is connecting some of the first results from the first study that Aditi Onag presented on poor levels of ventilation within healthcare centers in Bangladesh. Do you have any sense, or what's your intuition, or even data better, about how much of the transmission in these end-stage renal disease patients is occurring in facilities versus community-level transmission? And are there things that maybe at the facility level that might be done to reduce transmission?
I think that's an interesting question. I don't know if we have any data on infection inside versus outside at the community level. And so I am not sure about that. But I will think that it might be mixed. And the fact that we are seeing that in countries like Guatemala or European countries or countries here in the United States, we have like the patient, we see that patients have like higher rates of infection. Patients on dialysis have higher rates of infection. I would think that there might be some connection between getting dialysis in a center versus just being at home without traveling or without being in a place where you have contact with healthcare workers, you have contact with other patients as well.
Well, thank you very much, Pablo. That's just a terrific presentation, and we really appreciate your active engagement with the Stanford Global Health community. We're going to move on now to our fourth presenter. Laurel Crow is a senior PhD in mechanical engineering at Stanford University. She's in the Prakash Lab. She has a master's degree in mechanical engineering from Stanford University and a BS from Olin College of Engineering. Laurel is a fellow of the National Science Foundation Graduate Research Fellowship Program, a finalist for the Hertz Foundation Fellowship, and a 2019 alternate for Stanford's DARE Award. So we're very pleased to have the engineers so well represented here. So please, Laurel, go ahead.
Great. Hi, my name is Laurel Crow, and I'm a PhD student of Professor Manu Prakash here at Stanford University. And today I'm really excited to talk to you about a highly collaborative project that we launched in the spring of last year in response to the COVID-19 pandemic. And a quick shout out to my lab members, Adam and Pranav, who are presenting posters later today on our other COVID-19 efforts in the lab. Please stop by and check out posters 1 and 30 later today. So I'll start here by giving a brief bit of origin about this project, and it requires that we go back to March of 2020. At this time, just over 30% of hospital personnel in the US reported that there were no masks available for use in their hospitals. And the official advice from the CDC at the time was for individuals to improvise. So at this time, even in the US, there was this urgent need for a stopgap solution to protect healthcare workers while supply chains of N95 respirators could catch up. And this need for robust, reliable respirator protection persists in large regions throughout the globe that still don't have access to adequate PPE supply. And that's especially so in regions where cost further prohibits access to this equipment. So in early March of 2020, my professor, Manu Prakash, was traveling back from a conference in France, and he had to quarantine for 2 weeks. And he was stuck in this room where he was storing his family's snorkeling gear, and he had this idea of using this recreational sports equipment as the basis for a reusable stopgap PPE. So if I advance the slide here. So the basic idea behind this design is utilizing a full-face snorkeling mask to interface with a medically rated ventilator filter. And our lab rapidly designed a coupler that could safely interface the airway pathways of the mask with this filter. And the mask is assembled by the user and consists of 3 parts: a full-face snorkel mask, a filter, and a coupler. And these filters may be reused for up to 7 days, and the coupler and the mask can be repeatedly decontaminated. So this solution is both low cost and reusable, a combination that makes it highly advantageous for many places throughout the globe. So we set out to characterize these masks and compare them to the current standard in hospitals, disposable N95 masks, and to some lesser extent, half-face elastomeric respirators. And I want to emphasize the fact that disposable N95s are the status quo in healthcare globally is kind of insane. The use and toss mentality of these devices makes the global system exceptionally fragile to economic pressures and supply chain collapses, as we've seen. Until very recently, these reusable alternatives were simply not widely adopted. So we thought about different quantitative metrics to compare this new device to the standards, including fit testing, filter performance, work of breath, CO2 concentration, valve performance, clinical usability, robustness of the device to decontamination, and different donning and doffing safety protocols. So a slightly complicating factor is that different clinicians are using these devices differently. Some of these configurations are shown here in this panel. Some examples involve the use of industrial-grade P100 filters when ventilators are in short supply, and another example is sealing of the forward-facing exhale valves for surgeons needing environments with a sterile field. So this study, we focused on assessing the simplest configuration, which is just an out-of-the-box filter, a medical ventilator filter on a mask with no additional modifications. So we'll start by diving into some of the results of our rapid research efforts to characterize the safety of these devices, and we began with fit testing. So this is a test to assess if the mask shape fits tightly on the face and to check for gross mechanical leakage in the overall system. And all of our tests showed results equivalent or better than NIOSH-rated half-face elastomeric respirators, even during a variety of tasks such as exercise, bending over, nodding, and talking. And we used 2 different testing protocols on a total of 6 different individuals. The first is a hospital standard qualitative fit test, which involves a bitter-tasting gaseous compound being introduced in the vicinity of the mask wearer. The second test was a quantitative test using a port count device, which counts the ratio of particulates outside versus inside the mask. The second set of assessments that were performed involved testing of any potential leakage in the chin valve, which is a one-way valve in the mouth compartment of the mask to comfortably allow exhale air to escape. So we tested these valves using a NIOSH standard back pressure test, which involves applying a suction pressure to the back of the valve and measuring the leak rate. And upon testing these masks, all appeared to consistently pass the NIOSH spec of 30 milliliters per minute at a back pressure of 22 millimeters per H2O. So while we're optimistic at these results, we're also slightly wary because medical manufacturing often involves extensive regulation, including frequent inspection of mechanical tolerances and batch performances. So the use of these valves in recreational sports should be done with some caution, and fit testing will typically indicate if a failed valve is causing gross leakage. And we caution our audience that these fit tests should always be done on individual units prior to use in infectious environments. So third, we looked at CO2 buildup in these devices. Our collaborators at University of Utah performed experiments on styrofoam headforms while performing measuring the CO2 levels. Clinical collaborators also performed these tests on medical personnel directly, and the levels were found to consistently be between 1% and 2% CO2, which is acceptable and comparable to elastomeric respirators. And finally, in collaboration with Dr. Simon Elgas of Waymo, we also developed a full CO2 species transport model using CFD to be able to compare the concentration of CO2 across different hypothetical configurations in order to quickly address the safety concerns of different clinician groups. However, across all these fronts, our model indicated that CO2 buildup varies only very slightly across all the different configurations that we tested and does not appear to exceed 2% on average. So to assess clinical usability, we distributed approximately 70 units to collaborating medical personnel domestically for use in non-sterile, non-infectious environments. And the internal feedback indicated adequate usability, good work of breath, and sufficient visibility. Some of our clinical collaborators in Chile later on reported usage periods exceeding 6 continuous hours with no poor effects and comfort levels that were better than disposable N95s. However, the most persistent critique that we received was that speaking can be muffled, especially in noisy environments. And in response, a team of undergraduate collaborators from Olin College spearheaded the rapid development of a free amplification app that just uses a smartphone and a set of wireless earbuds to improve critical communications between users and patients. We then tested the filtration efficiencies and pressure drops of a large number of these ventilator filters and filter materials on a small testing rig in the lab at Stanford. We also worked with a couple of filter manufacturing companies, Paul and Medtronic, to develop guidelines for use and accurate information on filtration efficiencies at different flow rates. I'll point any interested parties to our website, where we have compiled a huge list of filters that are most recommended for use in this application. So in conclusion, across our different quantitative metrics, we found this new mask either comparable or superior to disposable N95s in terms of respiratory protection. But it has the added benefit of incorporating a face shield and being robustly reusable for hundreds of cycles of decontamination. So for these reasons, we're very optimistic about this device, not only as a stopgap solution, but as a model for laying the foundational design principles of future PPE globally. The current standards in the medical industry for reusable PPE, such as PAPRs or positive air pressure respirators, cost between $2,000 and $5,000. They're simply too expensive for the majority of clinicians worldwide to access. But this reusable device proves that far lower cost options are indeed capable of providing suitable protection. To wrap up here, I'd like to discuss a bit about how this project rapidly left the lab and entered the real world during this pandemic, with the help of several large collaborators from industry that took ownership of Scale Up. By May of 2020, as you can see on this map, we had donated thousands of these masks domestically to hospitals in need. And by the end of July 2020, the device was approved by national regulatory agencies equivalent to the FDA in France and Belgium, directly using our data to help support their respective regulatory approval processes. And the collaborators have now distributed tens of thousands of these devices internationally across 7 different countries where they're in use. So collectively, we were only able to achieve this because of a rare and a radical kind of openness and collaboration with researchers across the globe. Our research methods involved a method of preprint sharing through a public-facing Google Docs lab notebook that was updated daily with test results. And we built global Slack communities who collaborated and offered informal feedback. It was an uplifting and honestly a life-changing experience to see such selfless collaboration crossing all lines, a community that spanned contributors in academia, in industry, and in clinical domains. And these folks came together to achieve the singular goal of getting answers quickly for clinicians who needed them on the front lines. And because of this spirit of openly sharing, there have been numerous spin-off projects we have also been involved in, from collaborators in Nepal using these masks to make fully functional PAPRs, to the ventilator SOS team at Arab who have been expanding the use of these masks for BiPAP patient therapies. So I want to spend the last minute here to wrap up. What major lessons did we learn here that will endure even post-pandemic? And one of the most critical lessons from the pandemic is that the global supply chain of disposable PPE is fragile, costly, and very wasteful. And our evidence shows that it is sometimes also less protective than reusable options, and that there exists this potential global market for low-cost reusable medical PPE. Even after this pandemic subsides, we ask the global health community to consider adopting low-cost reusable PPE solutions as an accepted standard in the community, and to consider the benefits of radical openness in future research collaboration. I will now take questions and point folks to our paper here at this link and our project website for further details. Thank you.
Thanks, Laurel, very much for your work and for your clear presentation. Our first question is, if there was one technical issue that you could address that would make this even better, what is the one technical improvement you would like to make in the mask?
Yeah, so there are a couple that are currently interesting possibilities. So the first technical improvement that is probably the lowest hanging fruit is that amplification tool that I was briefly mentioning, and we currently have an Android app for that. But the muffled speaking is the biggest issue for our users. And the way that app works is you take a Bluetooth headphone and you put it in the center portion of the mask, so it captures your voice, and then your phone, which is on the outside of the mask, receives the audio signal and can broadcast that. And right now we have an Android version that is available and open, but we have not yet finished the iPhone app, and a lot of the users that we've been communicating with do have that other platform. So that's one improvement that is still ongoing in development. The other that we've heard from clinicians in terms of how they have taken this and improved it is, like I mentioned, our collaborators in Nepal have been adding pumps to create positive pressure devices, and also putting on disposable hoods over the top, so to completely seal off any potential exposure, infectious particles landing on the hair or whatever. So you have complete sealing of the device. But those are two examples that would improve the device.
Thanks. The next question is, what are the challenges you foresee for these reusable masks to be widely accepted in medical communities as compared to the currently standard N95s?
Yeah, so I think that the most critical and honestly the most troubling piece of the entire project is that the medical supply industry has these regulations where they will go and they will check different batches to make sure that each batch that is produced by a certain company is up to spec for that particular batch, and they do this kind of randomly. Typically, the inspections are once per year for medical manufacturing in the U.S. And the biggest problem with these masks is that we don't have that layer of security. So if there's a snorkeling company that is producing a mask and they have an injection molding part go bad, and then they have a bunch of masks that are produced for that particular batch that all have terrible valve performance. We have tested many dozens of these masks, but it would be difficult to know that an individual unit is always safe. So I think going forward, some sort of medically certified version of the snorkel mask base product would really help clinicians long-term adopt this past the pandemic and past this kind of emergency, what do I do in the next week kind of mentality.
The next question is, what has been the user experience, specifically around comfort, in comparison to N95s and PAPRs?
Yeah, so typically our users have reported that the comfort is better than most N95 masks that they have available in hospitals, partially because well-fitting N95 masks will kind of bite into the user's face. And in this particular case, we have this soft silicone seal that nicely has a larger surface area, so there's less pressure on the face particularly. And that has led a lot of people to use it for very long periods of time. However, the PAPR thing is a very interesting question. It's definitely not as comfortable for long-term usage as PAPRs. For those folks who are interested, PAPRs usually you have some sort of air port into the mask that provides a pressure of a flow of air, which makes it much easier to breathe, and you have a constant flow of air through the mask that's powered by some external source. And so this is powered only by the user's breath, and the benefit of that is it makes it much less costly. The downside of that is that the user has to do all the work. So you are creating all of that pressure yourself from your lungs. So it is better than N95s from the feedback and worse than PAPRs.
Well, thanks, Laurel, very much. We really appreciate your contribution in this area and the whole contribution of the lab and all your collaborators. We'll move on now to the next presenter. The next presenter is Marissa Childs. Marissa is a PhD student in Stanford University's Emmett Interdisciplinary Program in Environment and Resources. Broadly, she's interested in how environmental conditions affect human health and well-being. In particular, she studied the effects of conditions on infectious disease transmission. Her presentation is entitled Small-Scale Gold Mining Increases Malaria Risk in the Brazilian Amazon. Over to you, Marissa.
Thanks so much for that introduction, Dr. Luby. I'm going to pivot from talking about the current pandemic to talking about gold mining and malaria in the Brazilian Amazon. Anthropogenic land use is a major driver of environmental change, occurring at staggering rates across the globe and causing pervasive impacts on ecosystems and the climate. But beyond these impacts, we also know that land use and land cover change can affect infectious disease transmission, from forest fragmentation causing Lyme disease to agricultural expansion associated with Nipah virus emergence. Another disease that we strongly believe is affected by land use changes is malaria, whose transmission by mosquitoes makes it very sensitive to environmental conditions. In particular, small-scale gold mining in South America is often hypothesized to affect malaria transmission. This is an image of small-scale gold mining in the Brazilian Amazon. There's a few key mechanisms by which this mining is hypothesized to affect malaria. First, you can see here that deforestation from gold mining creates forest edge habitat and small pools from mining that create ideal habitat for the Anopheles darlingi mosquito that's the main vector of malaria in the Brazilian Amazon. Second, you can see in this lower corner mining equipment and structures. This suggests that people are living and working in very close proximity to the ideal vector habitat. And finally, we know that gold miners are a very mobile population, which really creates the potential for spread of malaria beyond these local mining areas. To recap, we have some clear hypothesized mechanisms through environmental changes, occupational exposure, and human mobility. And while case studies and epidemiological investigations have found very high prevalences of malaria incidents in mining areas, we really don't understand the total effect of gold mining on malaria. We don't understand its importance or its scale, and we really just can't quantify yet the total impact on the landscape. So this led us to ask, first, how much does small-scale gold mining affect malaria transmission in the Brazilian Amazon? Second, given our concerns about human mobility and spatial spillover, we asked whether these effects extended beyond the location of gold production. And finally, how important are these effects in the overall landscape of malaria transmission? Malaria in Brazil is primarily caused by two parasite species, Plasmodium falciparum, shown in red on the left, and Plasmodium vivax, shown in blue in the center. Here, darker colors indicate higher incidences. And while we might be able to see visually a spatial pattern between malaria incidence and gold production, shown on the right, we really can't use that to identify a causal effect of gold production on malaria incidence, because we know that a whole suite of other covariates drive both malaria and gold production. So to handle this, we use a Poisson regression that includes gold production as well as those other covariates, and unit fixed effects as well as region year fixed effects. In particular, these unit fixed effects, or unit dummy variables, account for municipality-specific characteristics that are constant through time. And these region year fixed effects account for common regional changes in both malaria and gold. Taken together, our approach identifies the effect of mining activity on malaria incidence by comparing each location to itself over time as mining activity fluctuates, controlling for both local changes in key additional malaria drivers and all common regional changes in both malaria incidence and mining activity. Further, as you recall, we were interested in both the local effects of gold production and potential spatial spillover. So we include both local and distant gold from neighboring municipalities in this analysis. Finally, We know that Plasmodium vivax has a liver stage, hypnozoites, that can cause relapses months or years after the initial infection, potentially making it more suitable for spread by travel of chronically infected individuals. This led us to hypothesize that while local gold production would have clear effects on both Plasmodium falciparum and Plasmodium vivax, the spatial spillover and distant gold would have a clear effect on Plasmodium vivax. So what did we find? First, looking at local effects. Here we have gold production on the horizontal axis and log malaria incidence on the vertical axis. Each solid line is the estimated response function between those two, and the shaded area is the 95% confidence interval. And what we find is clear local effects for both malaria species, with higher gold production associated with higher malaria incidence. Moving on to distant effects, now we're going to look at distance from production on the horizontal axis and the marginal effect on malaria on the vertical axis. First, for Plasmodium falciparum, you can see on the far left that clear local effect that I was talking about before. But beyond that, we really can't detect an effect on malaria incidence from more distant gold production. Now looking at Plasmodium vivax, we again can see that clear local effect on the far left, but we also see effects on vivax detectable up to 250 kilometers away from the location of production. This led us to really want to understand what the relative impacts of these two effects was, given that distant effects could be affecting many municipalities in the area around the production. So to look at this, we estimated the additional cases due to an additional kilogram of gold for both local and distant municipalities. First, looking at local, here each point is an individual municipality and the colored lines show the average effects. We can see that for falciparum, we estimate an additional, on average, half a case for an additional kilogram of gold, and an additional 2 cases for an additional kilogram of gold is the estimated impact for vivax. Turning now to distant effects, we can see that for falciparum, we estimate on average 0 cases, which is consistent with no detectable impact on distant municipalities. On the other hand, for Plasmodium vivax, we estimate that on average, each kilogram of gold causes an average of 58 additional distant cases of malaria, really suggesting that in total, these distant effects can exceed the local effects. Now, scaling up, we wanted to understand how many malaria cases could plausibly be attributed to gold production. To do this, we estimated the malaria incidence if gold production were removed and compared that to the estimated malaria cases if given the observed gold production. Here I'm going to show you results for Brazil in 2015. First, for Plasmodium falciparum, here I'm showing you a map of those estimated effects, with the gray area showing the outline of Brazil and darker colors showing higher estimated cases attributable. And what we'll really notice is these effects are centered on mining areas, where primarily these effects are only in mining areas and everywhere else we can't see an effect. For Plasmodium vivax, we see that those effects are much more distributed across the landscape. These effects are widespread, suggesting really large spatial scales at which gold mining is affecting malaria transmission. And in total, we estimate about 47,000 cases of malaria are attributable to gold mining in Brazil in 2015 alone. So to wrap up, first we had asked how much does gold mining affect malaria transmission in the Brazilian Amazon? And we find that there are clear effects within the municipality in which gold is produced. Second, we had asked about spatial spillover. And we find that consistent with differing parasite biology, we find effects only on Plasmodium vivax, and those effects are detectable up to 250 kilometers away from the location of production. Finally, we had asked about the total effect on the landscape, and we estimate that thousands of cases are attributable to gold mining each year, suggesting a really important role that gold mining has on malaria. And finally, I just want to emphasize the implications of these distant effects on gold mining, where spatial spillover from mining regions can become sources of malaria and undermine malaria control efforts, suggesting that this is a really important consideration for future planning. Thank you so much for your attention, and I'm happy to take questions.
Thanks, Marissa. This is really interesting work. A few questions have come up. First is, how do you, when we look at the broad land use alterations across the Amazon, which I think the only adjective we could use is, destructive. I mean, they're really destructive land use changes. How do you feel like this work on malaria contributes to the narrative that is ongoing in Brazil about what to do?
That's a great question. I think that we're beginning to understand more and more how destructive those huge landscape scale alterations are. I think for a long time we've known the environmental impacts, but the health impacts of those are still emerging. I think an additional complication here is that small scale mining is often illegal. And so I think by stigmatizing miners and mining, we actually create a difficult situation in which it's really hard to get healthcare to these people who really need it. And I think that's a key way in which we can, while it won't get rid of the mining, it will help to prevent these enormous health impacts. So I think this is yet another case in which, unfortunately, these enormous land use changes have a huge health impact. But I think we need to be careful in how we think about and deal with it, because just decrying gold mining and gold miners as the villains here won't really solve the issue.
Mm-hmm. It's really a illustrative example of planetary health, how the health of the community in Brazil depends upon the health of the environment. Another question is, this analysis is presented suggests a certain equivalence in terms of counting malaria cases, that we have acute cases that are largely falciparum, perhaps, and we have chronic cases that are largely vivax. Given that falciparum has a higher case fatality rate, have you thought about what this analysis how it might change if one considered this in terms of disability adjusted life years or some other metrics that didn't just equalize burdens from falciparum and vivax?
Yeah, that's a great question. And a step we haven't taken yet. I think there is the potential that we could, that would create a greater weighting on the falciparum cases. Generally, people have much more severe disease and they have these very chronic illnesses that can be very debilitating. I think on the other hand, we've seen in Brazil that the Brazilian government has made massive efforts to reduce the malaria burden and have been really successful, particularly for falciparum. On the other hand, for vivax, the malaria incidence is just so much higher. I think about 90% of cases are caused by vivax and only 10 are caused by falciparum. So I'm not sure we'd really undo that extreme weighting just caused by the current prevalence if we were to take into account disability adjusted life years.
Great. Last question is, you have put forward a really careful statistical model, but you also jumped pretty quickly into causal language. How comfortable are you making causal inference on these observational data?
That's a great question. I think it's a really hard question. I think it's always hard to identify a causal effect. But in this case, and I won't say we are certain, you're never certain. I think we have done the most careful job we can. By using this kind of analysis with fixed effects and accounting for other variables, we're trying to very carefully pin an effect of small changes in gold mining to small changes in malaria. So we've taken out all of the cross-sectional spatial correlations because we don't believe we can attribute those to gold production, despite the fact that we do see very clear spatial patterns. And I think, unfortunately, these kind of things, it's very hard to have a causal, the like ideal causal experiment, no one's going to want to do. No one's going to introduce mining into a location just to see what its effect on malaria is. It's just like neither feasible nor ethical. So I think while this is imperfect, certainly, I think it's one of the best ways we can try to detect these impacts. And so I think, yes, I did use some causal language. And I think we are getting very close to identifying a causal effect here.
Well, thank you very much for the presentation. And if we're going to be effective in the world, we also have to be willing to speak the language. So, so thank you very much. We're going to move on to our last oral presentation, and that will be from Sarah Mazzani. Sarah earned a bachelor's degree from the University of San Francisco and a master's degree in cell and molecular biology from Tulane University. She's currently working as a research scientist with Unidos en Salud, a unique partnership among the San Francisco Latino Task Force for COVID-19 in UC San Francisco researchers, the City and County of San Francisco, and the San Francisco Department of Public Health. Her presentation is titled Evaluation of a Novel Community-Based COVID-19 Test-to-Care Model for Low-Income Populations. Sarah, we are waiting for your presentation. Please go ahead.
Good morning, and thank you, Steve. Good morning, everyone. Thank you all for joining us today, and thank you to Stanford Global Health for inviting us to share a little bit about the work we've been doing in San Francisco in response to the pandemic. First, I would just like to briefly acknowledge the large group of people and multiple teams who were involved in making this project come to fruition. As you mentioned, the Division of HIV, Infectious Disease and Global Medicine at UC San Francisco, the San Francisco Department of Public Health, the San Francisco Latino Task Force, the Division of Epidemiology and Biostatistics, the School of Public Health at UC Berkeley. Thank you to all of our collaborative partners, and thank you for allowing me to present today on their behalf. First, I'd like to tell you a little bit about the background on how our test-to-care model came to be. A community academic partnership was formed between UCSF and the Latino Task Force approximately 6 weeks into San Francisco's shelter-in-place last year in April of 2020. This community academic partnership formed Unidos en Salud, which underpinned the design of Unidos en Salud study and all subsequent study activities, including the test-to-care model. This 3-week demonstration project, which was essentially a multi-component intervention, was nested within the Unidos en Salud test and response study, which was an epidemiologic surveillance study that took place during April 25th through 28th in San Francisco's Mission District. This community-based COVID-19 outreach and testing campaign was undertaken in a single, densely populated, highly diverse US Census tract. This census tract represents a 16 square block area located in San Francisco's Mission District. Within this census tract, there's approximately just a little over 5,000 residents, of which 58% are Latinx. It is worth noting that in San Francisco's Mission District, it's historically and predominantly a Latinx community. However, over the past 2 decades or so, the Mission District has undergone substantial gentrification, which has resulted in escalating housing costs and ultimately displacement of many of the Latinx residents. But the initial project originated when this test and respond study was this mass testing that we were able to mobilize in the community with our community health workers and go door to door, advising people of this upcoming testing event. This led to a 4-day mass testing in which we were able to test just under 4,000 of the residents within this census tract. And at that time, we were testing PCR for COVID as well as antibody testing. The multi-component aspect of this study was unique in the sense that in addition to providing this mass community-based testing, we also were providing a linkage to care and ongoing support for those individuals who tested positive. Now I'd like to talk to you a little bit about the test-to-care model. We evaluated this model using the RE-AIM framework and drew upon multiple data sources, including programmatic data, informal interviews with participants, providers, and community health workers, and structured surveys among participants. This figure provides a little bit of an overview of our care model, which shows the integrative and synergistic nature of the flow of care between what we called our clinical response team and our community wellness team. So the clinical response team would be represented here by the orange and the green parts of our care wheel, and the community wellness team is represented by the yellow and blue teams. So just to sort of outline a little bit of the flow of how that worked. So if participants were to test positive at the mass testing event that I referenced in previous slides, we would enter the care wheel here, where results would be disclosed by our clinical response team, and an initial clinical and needs assessment could take place. From here, the clinical response team could also, through various surveys and phone calls with participants who tested positive, we could assess if in fact the participant would be interested in a linkage to our community wellness team. And the community wellness team was then very actively involved in providing many social support services to these patients who tested positive so that they could safely and effectively isolate and quarantine. So the goal was to really have this wonderful care wheel, which was very fluid. So we weren't operating in silos. We were really interacting with one another and had this excellent linkage between the two aspects of care, our clinical as well as our community-based response. Now I'd like to talk a little bit about the reach of our study. Reach we defined according to the number of COVID-19 positive patients who were successfully contacted by our clinical response team for disclosure of their results from their COVID testing, as well as an individual needs assessment. And we were interested in knowing which of these participants wanted and were provided social work support and community-based support from our healthcare workers, our community health workers who compose the community wellness team. So from that initial mass testing event, we had 83 participants test positive, PCR positive. Of those 83 participants, 80 were reached directly by our clinical response team. And from those 80, 60 of those participants identified that they were interested in being contacted by our community wellness team, the support component of our test to care model, for further supportive services. So again, of the 60% that were referred to us, we were able to reach 58 of those. And just to tell you a little bit about the background of, at the time, again, this is from April of last year, of the initial 83 patients who tested positive, 76% were male, 95% were Latinx, 88% of those patients reported having a household income of less than $50,000 annually, and 93% of those were unable to shelter in place. So of these 58 participants that we ultimately made contact with to provide the care component, we were able to discover that 88% of those households were in fact interested in receiving direct home support. And the goal of this was to really enable these families. As we mentioned, many of them are very low income, socially, economically vulnerable populations who needed to find a way to successfully isolate immediately upon receiving their diagnosis. So we were able to make contact with these patients within 24 hours of their disclosure of their status resulting from the testing. So we provided basic cleaning supplies, PPE, groceries that were graciously donated by Grocery Outlet. And another interesting component that we discovered through this reach and impact data was, in the beginning, initially, we thought we were supporting 58 participants, but after the community wellness team was able to establish rapport and develop trust, over multiple phone calls and checking in on these patients and continued interaction over the 3-week period that they were participating in the care component of our model, we in fact learned that those 58 participants in reality represented a total of 239 unique household members. So it just really highlights just how dense some of these households are. And they're not all necessarily multi-generational families, but some of the things we learned are there are multiple unique families that this, in other words, maybe 3 or 4 families who are not directly related to one another, but who are living in these smaller urban apartment dwellings, etc. So we really reached a huge number of people, thinking it was initially going into it a very small amount. And in fact, over 200 people were supported, which we're very proud of. So in conclusion, with respect to implementation, we did find that the test to care model was feasible and highly acceptable intervention for supporting self-isolation and quarantine among newly diagnosed COVID-19 patients and their households by directly addressing key barriers faced by socioeconomically vulnerable populations. Participants, especially those who received community-based community wellness team services, they expressed gratitude and high levels of satisfaction. So it just really illustrated that the comprehensive care model is so important to accompany testing, because with just testing, we're beginning to question its efficacy if in fact it's missing the critical component of care. Many of these populations face substantial barriers to isolating, to oftentimes they're faced with making a choice between, do I stay home and quarantine and protect my community, or do I need to go to work and with a positive status so that I can feed my family? So another result of our project was we ended up, some of our data was able to inform policy while working with the supervisor, Hillary Ronan, who's the supervisor of the Mission District, we were able to establish the Right to Recover Fund, which was privately funded and was able to provide low minimum wage replacement for these people, the equivalent of the 10 days of isolation. Their wages would be replaced with this Right to Recover program. So we have identified that in a perfect world, it really is optimal, in addition to having the care model, that we also have some type of a low barrier financial assistance to assist these people with some of their basic living needs. And lastly, our next steps and some of our future projects. One of the additional discoveries that we made from some of this work was that most of the time, 50% of, this is preliminary data, which hopefully will be coming out in the next few months, that we're finding 50% of household contacts are often infected. The virus transmits rapidly through households and families. And of these households, only 37% of close contacts complete testing, follow through and get tested. Meaning if one positive person in a home comes home, only 37% of the rest of the household members which will get tested. So often many of them don't know their status. They're going out in the community, and we just have really identified that transmission within households is a significant driver of this pandemic. So I'm currently working on a home testing mobile test and trace project to hopefully learn more about the prevention of transmission within these households and continue to make progress in getting this pandemic behind us. Thank you.
Thanks, Sarah, for really presenting this frontline intervention during this difficult time. I'm really struck by the 93% of the group that you were working with being unable to shelter in place. And as we think here, we have time just for one quick question because we're running a little late. This looks like an intensive effort that was really successful in this few hundred people, But of course, we're dealing with a big epidemic in California and a global pandemic. Can you just talk to us a little bit about what you see as the implication of these findings for our current moment, when so many people who are at highest risk are really not able to practice behaviors that will reduce their risk?
I think one of the unique and most helpful components of this test to care model is in fact the care model, because as we're seeing, testing alone without action, without support it's limited, extremely limited in curbing transmission. So one of the benefits of utilizing community health workers and enabling and empowering CBOs and various communities to go out and form these teams and replicate these models is that it affords an opportunity for further education to inform these patients on how to safely and effectively quarantine and complete the isolation. And it also really has heightened certain behaviors for us that we weren't previously aware of, such as many of these families share beds, for example, multiple family members sharing a bed, the using of masks. So I think right now we're just really focused on doing what we can to mitigate transmission in these households. And we know without a doubt that testing on its own is just not enough.
Well, thank you very much, Sarah. Thanks for your contribution to the community, to your group's efforts against the pandemic, and for your clear presentation. I want to move on next to invite Dr. Michelle Berry back onto our virtual stage to give a brief overview of the Center for Innovation in Global Health's work. Michelle, over to you.
While we're waiting for this to come up, I just want to congratulate all the speakers and the chosen presenters. It's clear that this is the breadth of activities that are happening not only at Stanford, but in the Bay Area is impressive. Olivia, I think the screen sharing is not working. So if you can set us up, that would be great. And I do want to say that this has been an amazing group of people orally presenting. And I hope people stay on to see the posters, because it'll be live, it'll be interaction. What I'm going to do now is update people on the Center for Innovation in Global Health and where we're going in the next 5 years and what we're doing. May I have the next slide? What we really want to talk about is what our mission is. And the mission for the Center for Innovation in Global Health, I hope you get a feel for this on this, in this research convening. It's committed to increasing global health equity. It supports and promotes and advocates for Stanford faculty, students, and staff working in global health. We're the hub for things in global health at Stanford, and we have 3 strategic areas. I wanted to go over these. We're just to bring you up to date where we're focusing our strategy on. One is on human and planetary health. The other is on 21st century leadership. And the third is on global health equity. And through these strategic pillars, we're working to have cross-cutting strengths in interdisciplinary collaboration, in technologic innovation to generate solutions. And I think you've heard a lot of the interdisciplinary presentations today in the technology, very innovative technology solutions. And of course, we always aim to have excellence in research, teaching, and clinical care. We have a small but growing team that the center has, ranging from our Women Lift group, our planetary health group, to an amazing group of folks that support us. I'd like to, all the way on the right is Olivia Page, who's been instrumental in bringing this research convening together. But I would say just about everybody on this photo has worked hard to bring this together and keep the center going. May I have the next slide? And we do have a core leadership, and our core leadership works in many parts of the world. And they work they're very dedicated to global health equity. Whether you've heard from Bonnie Maldonado, Paul Wise works primarily in Guatemala, but also in areas of conflict. Ami Bhatt runs our global oncology. Sherry Wren runs our global surgery. Gary Darmstadt is involved in maternal and child health along with Bonnie. We have a lead for technology and innovation with Anurag Mairal. And you've heard a little bit from the Prakash Lab on bioengineering and frugal innovation. We have Jeff Tabin, who does global ophthalmology and is working to cure blindness around the world. And I was actually noted by Nicholas Kristof to be one of the 3 best places to donate money. Steve Luby, who is your MC and extraordinaire Dean of Research, works in many places, not only Bangladesh, around the world. And we have 2 people, Maha Mahadevan and Matt Strello, who do global emergency. That's the core leadership. But I have to tell you, there are 16 departments that have globalized. Just for a little bit of a deeper dip, because I didn't talk to you about Women Lift Health. Women Lift Health is a new Gates-funded initiative that is spearheaded by Amy Batson and Shireen Bond. And their goal is to put 3,000 women in global health leadership positions over the next 10 years. And they are working very hard. We're into our 2nd cohort now. And we will be opening up geo-hubs in India and East Africa as well. The other area that we're starting to concentrate on is, as I said, human and planetary health. This is just to give you an idea of what planetary health is. It's more than just the planet. It's more than global health. But these are all the areas that play into the fact that we cannot have a healthy human being unless we have a healthy planet. So it's not just about climate change and its impact on health, but it's about food and nutrition, waste management, sustainable fishing and how that impacts on health, wildfire management. We have a wonderful person. We have a group of people working on that led by Carrie Nadeau in our center. Environmental exposure to contaminants. I think Steve Luby has done some wonderful work with lead poisoning and lead introduction into spices like turmeric. We're about to start a curriculum in One Health and human and planetary health that will bring this curriculum into the medical school and residency programs. And we have a group of students helping to bring climate curriculum into the medical school programs. So we're working towards a healthy planet and a healthy people, as well as environmental social justice. So what have we done to try to go forward with this? We've been very lucky to have a donor to help us start the first new postdoctoral fellowship. And we're working with in human and planetary health. And we're working with the London School of Tropical Medicine. We've already selected our first 2 fellows. They will spend 1 year doing work at either London or Stanford, and then do a deep dive into the developing world. One will come from a high-income country and one from a lower middle-income country. And we have our 2 chosen fellows. One's from Canada and one is from Peru. And interestingly enough, they're both working on the impact of climate on mental health. We have spearheaded a new action lab for planetary health. So many of our researchers, and I think you've seen very interesting projects that have come to conclusions, but they don't get to the influencers who are going to make a change. So this is a lab which will write actually white papers and get to either the government official in the developing country or the US government official here with white papers that can actually move their conclusions onto implementation. I think that's been a problem for the academy, is that we publish lots of papers, we come up with lots of fascinating ideas, but then they don't move into action. And then our other goal is that the fact that we're never going to get our hands around human and planetary health unless we generate a multidisciplinary commitment. And Steve, myself, and 27 other faculty are pushing to start a new center in human and planetary health, and to interface with the new school of sustainability, which will hopefully begin in the next couple of years. So lastly, I wanted to just end with what opportunities, if you stick with the newsletter, you'll find that we have a lot of exciting things happening. There are upcoming global health. We have a fascinating conversation that will occur on February 3rd with Paul Farmer and Paul Costello, our interviewer for these global iconic conversations. We have a webinar in CUGH. Paul Wise and myself have come out with a new Lancet series on women and children's health in conflict settings. And it's going to be launched on January 25th, but we're going to run a webinar on this on February 11th. Our students, and I really give credit, they have faculty support, but it's really a grassroots student mini symposium, follow up on their larger symposium on climate and pandemic resilience. And they have Dr. Renee Salas from Harvard speaking on February 18th with others. On March 8th, which is International Women's Day, we're going to do a celebration of Women Lift Health. And I just gave you a little thumbnail of what we're doing, and we'll go further into that. And I hope you join us with that. And then lastly, we're about to have, I think you've seen many of the presentations today. We're actually funded by seed grants, and at late spring, we will be calling for another seed grant RFA, request for proposals. So take it away, Steve.
Well, thanks very much, Michelle, for providing that update. You also opened today with the tribute to David Katzenstein. And, this has really been hard for us because David was a beloved member of our community. And I think all of us are just really hurting right now who knew him.
I have to add to that, Steve, is that James Hakeem, our collaborator from Zimbabwe, also died on a day before David died. And James is someone we've collaborated with for 25 years. So I just want to give credit to our Zimbabwean colleague also, who fought, another selfless individual who fought for the country of Zimbabwe's health. And as you know, we've had a longstanding relationship and been twins with the University of Zimbabwe. So it's been heartbreaking the last couple of days.
It has been really heartbreaking. But yet we also made a decision to dedicate this convening to these people who have contributed so much to Zimbabwe in the world. And I just want to hold up for a minute what that contribution has been. That has included a commitment to research. There were a research convening. They generated great research. Much of David's work with Dr. Hakeem was working on HIV and reducing the burden of HIV in Zimbabwe. But in addition to research, these were people whose lives were committed to social justice, who were committed to bringing improved health to these communities. And so I think we hold them up as models. And also, David was just such an incredible person at building community, at having people over to his home for dinner, at bringing folks together. And so part of what I want us to do as a Center for Innovation and Global Health here at Stanford is actually to live out and as a tribute to their contribution, to think about this as a model for us going forward. So it has been a tough week, but they have made inspiring contributions. And I agree with you. I think the speakers were awesome. Thanks all of you for your work, and thanks for bringing it to this broader community. And I have noticed the participants checked in early and the participants have stayed. And that's really a credit to the engaging presentations that were had. I also want to call out a couple people. The whole CIGH team worked really hard to bring this together, and everybody deserves a thanks. But I want to call out a couple of people who really made this run. First is Olivia Page. Olivia, thank you so much for all of the planning, for always being a few weeks ahead, a few minutes ahead, and all of your troubleshooting as this has gone on. That has just really been super. And there's another unsung hero here I want to call out, and that's Jill Mueller. Jill, who works as a program assistant in the Luby Lab Research Group, also has done all of this work in organizing all the abstracts, figuring out for review, and helping us really do all of this. So really thank those of you who have contributed so much to this effort. We're now getting ready to go on to the poster session. And the poster session, when we do this live, is really very engaging. In fact, we always have a hard time pulling people back away from posters. It's going to be a little more difficult to do with Zoom, but we can do it because there are now virtual tools. So the poster presenters will be active on Zoom meetings to answer questions about their research. So when you navigate to the poster tab, they'll see a list of poster presenters by name. You may also refer to your poster presentation guide that was emailed to you. Presenters for posters number 1 through 20 will be live in the Zoom meeting for the next 30 minutes. So that is until noon. And then presenters for posters number 21 to 43 will be live in their Zoom meetings for the following 30 minutes. Just like a real poster presentation, we encourage you to browse several of the poster presentations, and the instructions are being displayed for your reference. So thank you very much for this, for your participation in these verbal presentations, and we look forward to your continued engagement on the posters. Thank you.